And welcome to MCPAP's monthly clinical conversations. I'm Marty Ravitch, the director of MCPAP. It is Developmental and Behavioral Health Screening in Pediatric Primary Care, featuring the SWYC Massachusetts tool. C stands for Survey of Well-Being of Young Children. A few notes before we get started. This will be recorded and will be available on the MCPAP website at www.mcpap.org. A PowerPoint slides will also be available separately from the recording and combined under Archive News and Webinars. Our presenter will be taking questions at the end of the presentation. However, today we're featuring some interactive poll questions. Hope you'll all be able to participate with those. If you do have a question or a comment during the presentation or during the Q&A period, please type into the box during the presentation, and we will either read out your question or unmute your line to enable you to speak. Of the webinar, you will receive a very brief survey. Read your feedback to help us improve our future presentations. So next, today's distinguished presenters, we have Dr. Ellen Perrin, who is a developmental behavioral pediatrician at Floating Hospital for Children at Tufts Medical Center and professor of pediatrics at Tufts University School of Medicine. She's board certified in developmental behavioral pediatrics. She's on the academic faculties of the University of Rochester, Vanderbilt University Medical School, and the University of Rochester School of Medicine before coming to the Floating Hospital in 2000. She and Chris Sheldrick developed the Survey of Well-Being of Young Children in response to the growing interest in comprehensive monitoring of children's development in primary care and other settings. Dr. Christopher Sheldrick, the Weber, a research psychologist at Floating Hospital for Children and an associate professor at the School of Public Health. Sheldrick is actively conducting research on autism and developmental screening in pediatrics. Closely with Dr. Ellen Perrin, he developed the Survey of Well-Being of Young Children. But significant, Michael Tang, who is an MD, board certified in pediatric psychiatry and child and adolescent psychiatry. Dr. Tang attended Harvard Medical School and completed his fellowship and residencies at Boston Children's Hospital and Massachusetts General Hospital. He is currently the Director of Behavioral Health Integration at the Dimock Center in Roxbury, Massachusetts. Turn it over to our presenters for a very exciting webinar today.
Dr. Tang, speaking again from Dimock. So just to start off, just to introduce myself again, I'm a primary care doctor at Dimock, and we've been using the SWYC for the last almost 2 years now, and it's really been a full resource as a primary care doctor so that we can walk into the room and have a great sense, even before the visit starts, about the entire milestone, psychosocial picture, and behavioral picture, knowing what to talk about with families before the visit even begins. So, the slide, please.
So, Ellen, we're going to start by just sort of talking about what screening is all about, and this is kind of a review, but clearly screening is an assessment for a specific condition that is performed independent of symptoms or causes for concern, and it identifies risk. So it differs from surveillance. Often those two terms are used in the same sentence, but they're different. Screening is standardized and involves a threshold that defines concern, so a normal and abnormal cutoff. Screening is recommended by the AAP and many other organizations at regular intervals, and what we paid a lot of attention to in developing the SWYC was screening has to be brief and efficient if it's going to be useful in primary care. So the reason for doing routine screening is that no one ever has enough time, money, programs, people, and so forth. Never enough resources. So the purpose of screening is to suggest how to allocate those resources and also which resources are most useful for which children and families. Mentioned that we are going to do some polls. You should be in a little box that has this question: what behavioral screening tools do you use routinely for preschool-age children? Because I don't think it'll take more than a minute to answer. And then, sorry. Marcy, can you move it from, can you get this off?
Is in press and people are answering.
Okay. Just let me know when it's...
Sure. No?
Let's move on to the second question.
I'm just going to take a few seconds. Okay.
So the section is, how satisfied are you with the usefulness of this tool? And let's move the polls pretty quickly because it won't take very long for people to answer these questions.
Okay, just about 20 seconds.
Good.
And then poll number 3.
So the question is, do you also use a screening test to evaluate children's cognitive, language, and motor development in addition to their behavioral status? And if so, what do you tend to use? Do you typically use? And
Should we wait for number 4?
I'm going to go on with the rest of the slides.
Okay. Should.
Can I get out of this? Maybe I can. Okay.
There we
go. Okay. So, in pediatrics, there's a sort of a list of conditions that, or criteria for what kinds of conditions should be screened for, and I'm just going to go through this so we can think about whether developmental and behavioral screening really meets these criteria. So, in general, a condition to be worth screening for has to be important, so it has to cause some morbidity, and common, must do slowly, to be treatable, and not only treatable, but it has to be more treatable if it's treated earlier, so result better if it's treated earlier. There has to be a reliable and valid screening test available to identify it. So those are kind of very generic criteria. So the question then is, are developmental delays and behavioral conditions, do they meet these criteria? First of all, are they important? Well, certainly over and over again have been determined to be the most common concerns that parents have when they come into pediatric visits. And we know more than 20% of children have a developmental and or a mental health disorder. We know special education services are used by large numbers of children and consume large amounts of budgets, federal and local budgets. The social and financial costs of developmental and mental health disorders cross many categories and are very considerable. So I think we could argue that they are important. So how common are they? And there are many regions and others in the epidemiology of developmental and behavioral problems, but I've already mentioned that social, emotional, and behavioral disorders account for 20% of children. Speech and language impairments are in the range of 10 to 15%. ADHD is about 10%, and so forth. So these are all relatively large proportions of children, and much larger proportion we find for most biomedical conditions that we treat. And the commonness, I think, meets the criterion. The couple of slides I want to show you come from the Mental Health Interview Survey, which is a telephone survey done nationally to a random selection of children. And you can see here is that for the past decade, the parents are asked whether their child has any limitation in the activities that they would expect for a child of that age. In the past decade, there's been an increase of about 15% in how many parents acknowledge limitations of activities in their child. And this is often used as an indicator of disability. What's really interesting in terms of our topic for today is that the disabilities, in fact, haven't changed or have changed very little in the past decade. In contrast, I keep doing this wrong. In contrast, developmental and mental health conditions have increased by about 21%. So there's a change in the epidemiology of limitations in children's activities, and they're pointing more and more towards neurodevelopmental and mental health conditions. Just another example or indication of the fact that this is a really important issue that we need to be really more and more on top of in pediatrics. So, going back to my list of criteria, are developmental and behavioral problems identifiable before they fully manifest themselves? Well, we know a lot about that. We know that early language skills predict later language complexity, and they also predict reading acquisition. There's growth that early signs of autism can be identified in some children before their first birthday. Or about the predictiveness of early temperament and school irritability, and it's many times now that these problems in the preschool period predict disruptive behavior disorders in adolescence and adulthood. We also, in the other direction, that more than 50% of adults who have diagnosed mental health disorders had symptoms in childhood that were not attended to. I think it's pretty clear that these kinds of problems are things we can identify early on, and that we can identify them before they're fully diagnosable. You know, the million-dollar question is, are they preventable or treatable? I'm going to say a few words about primary prevention, secondary prevention, and then tertiary prevention, which is really treatment. So primary prevention is intervention that's applied to an entire population. Secondary prevention is intervention applied to a subpopulation of people at risk, and treatment or tertiary prevention is obvious. So we know a lot about primary prevention of developmental and behavioral problems, starting from rubella vaccine, folic acid, limiting alcohol consumption, reducing prematurity, reduce environmental lead. All of those are kind of issue point and don't really need much discussion. The other items on this slide are a little bit more on the edge, in the sense that there's more and more information that parenting education and primary prevention of developmental and behavioral problems can work. There is some indication that it can work even in the context of pediatric care. And we also know that early literacy programs work, like Reach Out and Read, and many of you are probably involved with that program. In terms of prevention, lots of children that we can identify as being at risk. So children born prematurely, children in poverty, immigrant children, children who have experienced abuse or neglect or trauma, with a chronic health condition, all of these children are at risk, and secondary prevention programs could be placed and prevent further problems. just as an example, two programs that have long-term follow-up in which secondary prevention was attempted. So one was done in an urban environment, the high school Perry preschool project, in which children in poverty were into a high-quality preschool program for a half a day, 5 days a week, and parents were provided with parenting education. What's interesting about this program is it's now over 40 years old, so there's 40-year follow-up. And I'm going to show you a slide which is only a very small part of the results they have, but basically in the program, who were the blue lines, were much more likely to be ready for kindergarten, were much likely to graduate from high school, earn considerably more money as adults, were more likely to own their homes, and actually a number of other outcomes that were way better than the group. An rural group that was a very similar program was called the Abecedarian Project, and very similar intervention. Just the results there, they had higher IQ test scores and math and reading test scores, more graduated from high school and went to college. They were when their first child was born. They had their income. Actually, most significant from a financial point of view, the biggest cost savings were that there was 5 times less crime. So there were considerable savings in the criminal justice system, and that fact is actually true for the Perry preschool project as well. These two projects are kind of prime examples of secondary prevention projects. They're really quite doable. So what about secondary prevention, emotional and behavioral problems? It's a little bit trickier, but there are programs that provide guidance to parents for situations where the children are at some risk, so around parental discord and divorce, around adoption, for children with ADHD or autism or other chronic conditions, guidance for parents around preventing and treating tobacco, alcohol, and drug abuse in their children. And there are individual counseling for parents, of course, for parents and for children. I have a lot of time talking about treatments, because I think you know all about these early intervention programs and their various components. They're variously studied, but all of them have considerable evidence behind them to support them as treatments for developmental delays and disorders. And again, you're very familiar, especially with the early intervention programs for very young children, kids below 3. With mental health disorders, again, I'm going to go very quickly through this, but there are cognitive behavioral therapies that have significant evidence behind them, especially for depression and anxiety. Psychological therapies that you know, family therapy, especially for eating disorders and oppositional disorders. So those all of these have evidence bases to support them.
Trent, this is Michael Tang again. Thank you for reviewing the evidence about prevention and treatment. Talk a little bit about what tests are available to do developmental and behavioral screening.
Sure. So I want to save time to talk about the SWYC, which is sort of one of my things to talk about. I'm going to go very quickly through some of the other tests that exist and then come back to the SWYC. So for cognitive and motor development, the Ages and Stages 3 has considerable evidence behind it and has been very well studied and is quite a good test for those parameters. The Parents' Evaluation of Developmental Status is frequently used. It has the advantage of being a very short screening test and being a very straightforward set of questions. It's important to note that the PEDS is developed on, is based on parental concern. So it doesn't ask parents to report on what their children do. It only asks them to report on whether they're concerned about what their children do or don't do. And then the Survey of Well-Being of Young Children, the the components of the SWYC that is cognitive, language, and motor development is the milestones component. And again, I'll be talking more about the SWYC later. With behavioral and emotional adjustment, there are actually more validated tests. So again, ages and stages has another social emotional ages and stages. For screening test called the Early Childhood Screening Assessment that has had some amount of newer tests, so it hasn't had as much study to it yet, but it's looking good. It's appropriate for children from 18 months to 4 years. The Strength Difficulties Questionnaire is another one we like. It starts at age 3. The Infant and Toddler Social Emotional Assessment, or the BITSE, is a parent-rated questionnaire starting at 12 months and going up to 3. And that's also a test we're familiar with and has considerable evidence behind it. And then, of course, the Survey of Well-Being Young Children, again, I'll talk about later, so I won't do that now. You're with the MCHAT for autism, and the part of the SWYC that addresses autism, again, I'll mention it later when we talk about the SWYC, but it's called the Parents' Observations of Social Interaction, or the POSI. There have been a couple of attempts at looking at the comparison, or looking at how well the POSI identifies autism, and it looks like that it's very similar to the MCHAT. So just ask you one more a fourth question, which is, what proportion of preschool children who screen positive on any of these behavioral screening tests that you use, what proportion of them in general do you refer for further evaluation or treatment? So, some 20 seconds to answer that question.
Okay.
Great. And the other, there's been a lot of discussion recently about the responsibility or the role of pediatricians in identifying social determinants of health or psychosocial risk. And that could include a lot of topics. So I just listed on this slide some of them: food insecurity, substance use, family violence, housing instability, parental depression, generally adverse childhood experiences, which you've heard much about. There are only 2 screening tests that address these issues that have been in the literature. One of them is called the SEEK, Safe Environment for Every Kid is the actual name of it. It's available for free on the internet. It's about one page long. It addresses a number of these issues. And then there is a section of the SWYC called the Family Questions, which also address this.
This is Michael Payne again. So if I'm going to summarize what you just said, you set up the criteria for whether a pediatrician should be screening for something, and it seems like the developmental and behavioral disorders meet the criteria for screening because they're important, they cause morbidity, they're common, they slowly, they can be treated, treatment gives better results, and risks can be identified through screening. I think our experience at Dimock before using the SWYC, and I'm sure other pediatricians can speak to this as well, it's interesting, as you described, there are different instruments that can feel disconnected at times, developmental instruments, behavioral instruments, autism screens, instruments about family context or parental depression. And even if we had the right instruments, there are feasibility barriers. Some instruments cost money. They all take time to administer and score. Within a practice, there's a question of who does that, whether it's a medical assistant or a nurse or a community health worker or the pediatrician themselves. And many of these are not connected to the electronic medical record, which of course create barriers with scoring and follow-up and tracking. And all of our practices are different. Some of us have more ability to follow up, and some have less. Some have more behavioral health integration with social workers, psychologists available. And so that's obviously an important consideration on screening. So thank you for presenting all this. Speaking a little bit about the SWYC.
let's talk about the SWYC. So when Chris and I developed the SWYC several years ago, the principles on which the SWYC were that behavior and development are really inseparable, that the family context is critical, and that we needed to attend to feasibility. So the tool needed to be brief, needed to be easy to administer and score, needed to be amenable to electronic administration and adaptable to being put into an electronic medical record system. Also, that the tool needed to be freely available. And as I said before, Mike, that it needed to maximize the information available to the pediatrician prior to the encounter with the child. So those were the sort of basic principles that we started with. We ended up with this tool has 4 components. One is what's called the SWYC milestones, and that really assesses cognitive, language, and motor development. The component is the autism screener, the POSI. And then a section about behavior and emotion, and those are called the baby pediatric symptom checklist, which goes up until 18 months, and the preschool pediatric symptom checklist, which is 18 months to 5 years, and then the family questions, which address parental depression and family stressors. So just an idea of how this is structured, the SWYC has a form for every age on the pediatric periodicity schedule, so a 2-month form, 4-month form, a 6-month form, and so forth. And you can see from this chart the components that are included. And basically, those components are included at all ages except for the POSI, the autism screener, which is how the MCAT is recommended is on the 16 to 30-month forms. So this is what I encourage you to pull this up on your head if you can while doing this, but I'll show you what this looks like. The website is just theswyc.org. An example of a SWYC form. We were told when we were developing this that the instrument could not go over 2 sides of one piece of paper, or else it wouldn't be usable in a pediatric practice. So that does. It's 2 sides of one piece of paper. This is an example of the 18-month form. And I'm just through the components of it. So on top of the first page is what's called the milestones, which covers fine gross motor, language, and cognition. It's always 10 items. Obviously, the questions are different at each age, but there's always a milestone section. And parents rate each activity as whether the child doesn't do it yet, somewhat does it, or very much does it, and then those points are totaled up, and the score that the child achieves is compared to a table, and that's available on our website as well. The first of the first page is the behavioral and emotional symptoms. So from 1 to 18 months, as I said, it's the baby pediatric symptom checklist, which consists of 12 items and is also scored 1 or 2, and you end up with 3 subscale scores. Or from 18 months to 60 months, the preschool pediatric symptom checklist similarly scored. There are 2 items about parents' concerns, whether the parents are concerned about the child's learning, development, and/or behavior. Then, in the appropriate age group, the POSI, looking at ASD risk. So the POSI consists of 7 questions, and behaviors are listed in such a way that on the right-hand side are the concerning items. So if there are 3 or more items checked on the right-hand side of the page, that indicates concern. And then on the second page are the family questions. And what we've chosen to include in the SWYC are tobacco and other drug and alcohol abuse, food security, parental depression, and domestic violence. And what we did for all of these was to use screening measures that had been validated by other people. We create our own. So these are all available. These questions are all available in other places, but we put them together into a format that we thought could be usable. Unique sorry, I'm going to skip here because the slides are out of order. So, one somewhat unique aspect of the SWYC is that there's we are including the Edinburgh Postnatal Depression Scale on the 2, 4, and 6-month SWYC forms. On all of the other forms, the PAQ-2, which is a well-validated screening tool for depression in adults, is included in the family questions. But on the 2, 4, and 6-month forms, we have the Edinburgh Postnatal Depression Scale, which is currently thought to best screen for postpartum depression. This is a bit out of date because the code to be used for that is no longer S3005. It was last year, but this year it's not. I'll talk about coding in a minute. And let's say a word about McPAP for Moms, which hopefully all of you listening know about, but I wanted to give you the website because this is a really unique source for parents who screen positive on the parental depression scale. Coding, just say that the SWYC is approved by MassHealth as a behavioral screening tool for children from birth to 5, and the typical screening code would be used, 96110. But EPDS was a separate modifier to that code. I don't want to say about that unless there are questions, but that's kind of the basics about coding.
Much, Ellen. So I just wanted to say how we use the SWYC in our practice here at Dimock. Medical assistants have printed versions of the SWYC for each age group by month, and they hand it to the parent who fills it out in the room, and the provider comes into the room and can take the form. Often it's actually hanging outside the door by the time it's completed. Review it to have a sense about what to talk about before going in. We built in within our electronic medical record, which is eClinicalWorks, a place for the provider to very simply type in and select the scores and the interpretation results for each of the aspects of the SWYC. My understanding is that users with Ocean Epic have a more built-in automated version as well. And then we can use those scoring results to drive the clinical conversation and if needed, referral. So our workflow here. Dr. Perrin, would you mind speaking a little bit about the follow-up that happens after positive results?
Well, I guess the thing to say there is that what we've heard from many people across the country is that one of the disincentives or problems with doing universal screening is that it's hard to have the time and resources to deal with the problems that are uncovered by screening. And I definitely recognize that that's a problem because once you ask, you have a responsibility to deal with the problems you find. So I'd be curious, Mike, how your office prepared to deal with that challenge.
I'd say it happened in stages. Behavioral health integration was a major piece. Just like as pediatricians, we are trained to learn about heart murmurs and identify, very high emergent risk, but also know when to refer or know when to monitor. We develop those same skill sets with behavioral health integration. We learn to, send to the emergency room or send to in-house providers for emergencies, but having integrated social workers who could do warm handoffs, who could co-manage cases, and who could help educate us as providers on the nuances of managing these has been really important. And it didn't happen all at once. But for, I would say, each aspect of the SWYC, whether it's the BPC, the developmental pieces, or even the family concern ones, whether it's the food insecurity or the domestic violence or the parental depression, having those resources available. I would say the resources that has been important for us is having community health workers who can do the resource support, so connecting families to food pantries or signing them up for food stamps. And that's also helped free up the social workers to focus more on the developmental and behavioral components. And over the last 2 years and really the last 7 years with integration, we felt more comfortable in building those workflows so that we could address each of those elements of the SWYC if they were to be positive.
So we're going to ask you one more poll question. Come up, but so
It's open.
great. So if a child scores outside of the normal range on a parent-reported screening test that has a sensitivity of 70%, approximately what do you think the chances are that the child truly has a behavioral or developmental problem? While you're answering that question, I'm going to hand this over to my colleague, Chris Sheldrick, who's going to talk a little bit about that psychometric indicators of screening tests.
Yes, be prepared for the fun part of the talk, which involves the numbers, but I think it's worth actually, and I'm obviously being facetious, hopefully that's obvious, but it's important because all the time screening tests are recommended because they have 70% at least sensitivity and specificity, and that's seeming really important. So I think it's worth just taking a little bit of time, just a few minutes, to think about what those numbers mean. Second, when the poll is done, what I'll try to kind of claim. Oops, it looks like I can do that right now. Sensitivities in the ranges that we're talking about for most screening instruments, are actually imply a fair amount of error. That's one thing. Secondly, it's really important to think about how those stats actually apply to individual patients, because they're actually group-level stats. And finally, I think the most important thing is that in setting kind of the thresholds for making decisions or the cut scores for screening instruments, it's really worth thinking about the trade-offs involved in making those decisions. So I'd like to say a little bit about that. So in order to avoid just talking about numbers the whole time, I'd like to just show this visually. So on this here, what you see is just a range of possible screening scores on sort of a generic screener. And the first to think about is how kids who don't have disabilities or don't have disorders are going to score. And as any clinician knows, you get a huge range of scores. So let's just kind of assume that those are happening in a bell curve. Now, if the screener works at all, then on average, kids with who are affected by some kind of problem or disorder are going to score higher. So that's what's shown here. But there's still a big range. And as everyone knows, there's some kids who score quite high who actually are doing okay and why they score high. It could happen for a variety of reasons. And there are kids who have problems who actually score quite low. So there's a big overlap between these distributions. It's easier to see. I'll flip one below the other, but it's meant to be the same. And like as Dr. Perrin referred to before, the last thing you need to make this a screening instrument is some kind of a threshold to determine who scores positive and who scores negative. Here you can see that everyone to the right scores positive and everyone to the left scores negative. Everyone below that horizontal axis in the red and orange, those are the kids who are affected by some kind of disorder. And everyone above the horizontal axis in some kind of blue are the kids from the healthy population. So just to kind of see here is that there is a fair amount of error. The TN stands for true negatives and the TP stands for true positives. So those are kids who are correctly classified by the test as either having no disorder or having a disorder. But the ones in the red are the false negatives, the kids who have a disorder but scored negative on the test anyway. So that's kind of an error. And the kids in the dark blue are the false positives, the ones who scored positive despite not really having a problem. So think about sensitivity. In my experience, sensitivity and specificity are the terms that are probably most familiar to clinicians in terms of hearing a lot, but the least understood because everyone feels like they should know what they mean but always forget because they're kind of technical. But here what you can see is that what sensitivity really means, it refers to the proportion of kids with disorders who are detected by the test. So this picture was drawn to reflect the fact that 78% of kids with disorders are being detected by this test. In other words, it has 78% sensitivity. So that of the gray at the bottom, of those kids who have disorders, 78% are to the right in that true positive light gray range. But it's important to remember that we're missing 22% of those kids still if we set this threshold where we set it here in this diagram. Above axis, we can think about specificity, because specificity refers to the proportion of kids without disorders who are correctly classified. So all those kids above the axis in gray, ideally we would like all of them to score negative, but in fact, in this is drawn so that 70% are in that true negative range, yet we have 22% of those kids scoring in the false positive range. So the stats that are always talked about, the sensitivity and the specificity, are always talked about in terms of the accuracy of the test. But a clinician, I think what you start to care about a lot more is what's called the positive predictive value. So what you know when you see a child is you know whether or not they scored positive. And the question is, if they scored positive, is there a problem or is there not a problem? So here, this is drawn, and again, this is just an example, but assuming a pretty accurate test, 78% sensitivity, 78% specificity, we're doing well, and it's assuming a pretty high prevalence of about 20%. If you look at all the kids who scored positive there, only a little under 50% are below the axis. In other words, if a child scores positive on this test under these assumptions, only not even 50% of them are actually going to have a real problem. So clearly, that obviously fits in with what Dr. Tang and Dr. Perrin are saying. There's real challenges of using these screening instruments in terms of what they apply and what clinical decisions you need to make, and ideally, the kind of system of care it really needs to be in. Moreover, it's worth thinking about how these apply to individual patients, because I think the other thing that's really obvious to a lot of clinicians is that if you compare a child who scores really high on a screening test, where the arrow is right now, to a child who screens positive but very close to the threshold, those children are often not at the same level of risk. And the reason for that is that positive predictive values, I was just mentioning, really averages risk across all those kids who score positive. We're really interested in if true that we're going to do something for all kids who score positive. Like, let's say we actually want to recommend, like the American Academy of Pediatrics does, that we actually refer all children who screen positive for evaluation or for treatment, then it has to make sense for each and every one of those kids. It doesn't have to make sense just on average. It has to make sense for all of them. And to make sense for all of them, it has to make sense for those kids who score right at the threshold. So worth thinking a little bit about what's the probability of having a disorder right at the threshold. Well, in this case, it doesn't have to do with the areas that are colored in. It has to do with the length of these lines. Because the length of the line on the bottom shows the frequency of kids who score at the threshold who have a disorder. And if you compare that to the length of the line overall, what you find is that the threshold probability in this example is actually only about 21%. So that the kids who were scoring positive, who just barely score positive in this example, only have about a 1 in 5 chance of really having a disorder. So it's worth really thinking about, do we have the kind of system of care in place to deal with that kind of kid? Is that what's a normal reaction? Because I'm guessing that at least some people on the call are thinking, I think, what a lot of clinicians think, which is that, well, that's not nearly high enough. I can't refer kids who only have a 20% chance of having a problem, and I'm not even so thrilled about not having a 50% chance of having a problem overall. So, one possibility is that, well, you don't refer those kids. The risk is too low. So what is, you only refer kids with a much higher risk. So let's say we set a new threshold at this error rate that's shown on this slide. And this was set very specifically to have a 50% threshold probability. So all the kids in that range have at least a 50% chance of having a disorder. But look up into the sensitivity. All of a sudden, we're detecting far fewer kids, a much lower proportion of the kids who have disorder. And with the sensitivity in this example, has actually fallen well below 50%. So there's a trade-off there, and it's the trade-off that's really important to understand. If you want to be right in every single referral, if you want to make sure every child who you refer has a disorder before you make that referral, then there's very much a benefit to that, and there's a positive aspect to that in that your specificity is going to be higher and your predictive value is going to be higher, and those referrals are more likely to benefit. But there is a downside in that some kids are going to be missed. So that's kind of overall message I think is important to really understand, is that there's this trade-off between sensitivity on the one hand and positive predictive value and specificity on the other hand. And where you move the threshold changes the balance between these two. So if you decide to only be sure before you refer, you're probably going to miss kids. At the time, if you are willing to refer kids even if you're not sure, well, you're probably going to have more false positives. You're going to refer kids who don't really need it. Another thing that we can think about is from a decision analysis standpoint, and don't be alarmed by these figures because I won't go into them in great detail. There's lots of fun math in there, which I highly recommend. But the basic message is that it comes down to the idea that if you make a referral, the reason you make a referral, you assume, is that you expect that the benefits are very likely to outweigh the risks and the costs. And on the other hand, if you don't make a referral, it's because you expect that the risks and the costs are very much likely to outweigh the benefits. It's just not worth doing for those kids. So the threshold is really going to fall is probably a point of indifference between the two, where the risks and the costs and the benefits kind of balance out. If screening is really going to work in terms of identifying more kids, we need two things. One thing is that we need more accurate screeners that give pediatricians more information to make better decisions more quickly, given the constraints on pediatricians' time. But the other thing that we need is a system of care that really maximizes benefits and so reduces risks and costs for both pediatricians and families. And I got to say, that's one of the reasons I was most excited to hear what Dr. Tang was talking about in terms of the system of care that's been developed at his health center, because that's the kind of thing that can really change this kind of cost-benefit balance for making referrals or for warm handoffs or for really acting with patients. So, to really send a message that thinking through those aspects of the system of care is every bit as important as the screening instrument that you choose. And if you'd like more information on all these lovely things, there's lots more math that's buried in the appendix, but also the basic philosophy that we have about the SWYC is really, as Dr. Perrin talked about before, it's about maximizing the information that's available to the pediatricians. Our manual, we talk a fair amount about what that implies, because it's obviously a lot less simple than just referring every child who scores positive. There's decisions that need to be made with clinicians, with other colleagues, with the family that suits your local practice and those families' needs. So we tried to at least begin to reflect that in the chapters we read in the manual. So, and now open for questions.
Well, thank you, all of you, for such a great presentation. It was really interesting and valuable and practical. So I have one question. What is the difference between the SWYC and the SWYC Massachusetts?
This is Ellen. SWYC Massachusetts is in the Edinburgh Postnatal Depression Scale instead of the PHQ-2 to assess parental depression at the 2, 4, and 6 month age markers, whereas the regular SWYC does not include those. However, that is likely to change in the near future. We're negotiating with the EPDS creator, the copyright holder, to make the SWYC be exactly the same as the SWYC MA. But at the moment, that's the only difference.
A question I had, actually, I noticed on one of the slides, I think it was 27, it says that the tool is soon to be in EPIC. Also, I think I heard Dr. Tang say it was built into eClinicalWorks. Is that accurate?
So the answers to those two questions are a little bit different. So we have just, within the last week or so, finalized an arrangement with EPIC so that the SWYC will be in its foundation program and therefore will be available to all pediatricians who have an EPIC system. We're excited about that. That's something we've been working on now for quite a few months. And we don't have a timetable on that, but most likely it will be activated in the fall. Chris wants to say something about it.
And just say a little bit about how that works. Our understanding, anyway, is that this particular system, it can be set up in different ways in different EMRs. It'll be set so that the parents can actually complete it online in a computer, and that their responses are automatically scored and automatically go into the medical record that the physicians see. So we've started to review some of their work, and it looks like a pretty nice system.
I'll speak to I can speak to clinical works at Dimock. We did, it's not so automated, but we were able to have, in-house, so not working with the manufacturer, but just within our own IT staff, able to put fields to enter the final scores and basically have a cheat sheet kind of built in there so that the provider could know, for a milestone score of 14 at age 13 months, whether that's positive or negative, kind of an easy way to score that. So I can say as a pediatrician, it's pretty intuitive. There was a little bit of legwork to get that in.
Thanks.
Well, I was going to say that we've worked with a number of other people across the country who have built the SWYC into various electronic programs, including some that have built it into a tablet that they give to parents in the waiting room, and some people have built it into a local EMR. So there's ways that this could be done, but the way that we've found so far is the way Epic will be doing it.
Great. We see any questions here right now. Another way you can ask a question is to click the little hand icon next to your name, and we can unmute you.
Waiting for another question. Could I say one thing, Chris, relating to your conversations about, sensitivities and specificities? One of the things I really like about the SWYC is essentially the same instrument is given at a visit, 2 months, 4 months, 6 months. And so even if there's someone who is kind of a little bit over the cutoff line, but as a pediatrician, you're not seeing a huge red flag clinically, it's very easy and comforting to say, hey, well, I know I'm going to see you back in 2 months or earlier if I want to bring you back earlier, and we're actually going to repeat the instrument so that if it's now positive a little over the line 2 times in a row or 3 times in a row, that's going to be assuring. That's going to be less reassuring, and it's going to make me want to have a lower threshold to refer. So that's one of the really nice things about having a quantitative instrument like the SWYC to make these judgment calls, and I think reinforcing as a clinician to use clinical decision making rather than feeling beholden to, if it's over the line, I must refer.
Well, here's one of the things that I think, actually, like in terms of that idea that you must refer the positives, it's one of the big points, I think, of confusion out there and that people really, really worry about. And it is important to know that the thresholds that we set for the SWYC, we really, because there's this trade-off, we really set them to try to aim on the side of sensitivity. We want to detect kids who have problems. And we recognize that for a lot of these areas, it is going to generate a fair number of false positives, which if you're trying to refer every single child who scores positive, that's obviously a big problem. You come at it the way that you're talking about, where you're trying to maximize the amount of information that you have and using the test to try to figure out, sort of, it works.
Thanks. I want to remind everyone on the line that if you do have any questions after using a screening tool about whether to refer or scoring, that's what MCPAP is here for. So please, feel free to call your MCPAP team and have a phone consultation. That's perfectly within the scope of what we expect for PCPs to call for. And as you hopefully know, we are also taking calls from behavioral health clinicians that are working inside your primary care practices as well. So if they have a question, they can call too. I don't think we have any more questions, so we're going to wrap up. I want to thank our presenters for a very stimulating conversation. If you do have any further questions, you can email them to mcpap@beaconhealthoptions.com, our general email, and we will make sure they get answered by one of our presenters. Just a quick reminder, you're going to receive a survey about the webinar. If you could take a moment to fill that out, really appreciate it. And also a reminder that this webinar will be available on our website at www.mcpap.org under the News and Archives section. Everyone, and we look forward to hearing them a month from now on the fourth Tuesday for our next clinical conversation. Okay.
Thank you.